Hi, everyone. I'm Dr. Cory Lappin, and I practice at Phoenix Eye Care and the Dry Eye Center of Arizona. And the focus of today's lecture is going to be the interaction between soft contact lenses and the ocular surface, and how contact lenses impact homeostasis. And here are my financial disclosures. So I'm going to get things started here with just a brief overview of homeostasis. So homeostasis is the central unifying concept behind physiology. And it's the process that allows us to live and adapt to a constantly changing environment. Essentially, the concept of homeostasis is that our bodies are going to try to keep physiological variables like body temperature within a certain set range, regardless of external and internal challenges. And it's also going to do this through the concept of dynamic equilibrium, which basically means exactly what it sounds like, which is changing balance. And a good way to think about this is a scale between our biological systems and environmental challenges like I have in this picture. And we have to add weights, so to speak, to the biological side to keep this constantly in balance. And a good way to think about this would be body temperature. So our bodies like to stay around 98 degrees Fahrenheit. So if we get too cold, we're going to start shivering to try to bring our body temperature up. Or if we get too hot, then we're going to sweat to try to stimulate evaporative cooling to cool us down. So really, regardless of the outside environment, we're trying to stay around that 98 degrees. Now, if we deviate too long, this is where problems can arise. And if we get too hot for too long, we can get heat stroke. Or if we get too cold for too long, that's when hypothermia can set in. Additionally, homeostasis is a feedback-dependent system that's integrated and self-regulated. So a good way to illustrate this concept is something we're all familiar with, which is reflexive blinking. So let's say we get a foreign body onto the ocular surface. What's going to happen is it's going to be sensed by the corneal nerves, and they're going to send feedback in the form of a signal to the brain. The brain is then just going to integrate this information, and it's going to send signals to the lacrimal gland and the orbicularis oculi muscle to tear and blink to try to flush the foreign body away so it can prevent injury and then maintain homeostasis. And then if you think about this, this requires no conscious effort on our part. So essentially, this is going to be a self-regulated system. So what does all this have to do with contact lenses and the ocular surface? Well, a lot, actually, because as you can even see here by the Dew's 2 definition of dry eye, it's right in the first sentence here. Dry eye is multifactorial disease of the ocular surface characterized by a loss of homeostasis. So homeostasis is going to be a major concept when looking at ocular surface health. Now, before we move on to discussing contact lenses specifically, I just want to mention that this lecture is going to be focusing exclusively on soft contact lenses, not scleral lenses or traditional gas perms, which would be a lecture unto itself. So when I refer to contact lenses in this lecture, what I'm referring to is soft contact lenses. Soft contact lenses are amazing devices, and they can do numerous things that have many benefits. The easiest one we know is visual correction, but we can use them therapeutically as bandage lenses, and we're even now using them interventionally with myopia management. But soft contact lenses also present a unique homeostatic challenge in the fact that they innately disrupt homeostasis. And the reason for this is because when we put a contact lens onto the eye, we're putting a foreign body onto the ocular surface. So that's going to innately disrupt this homeostasis. It's going to disrupt the tear film. And that's one of the reasons it's actually thought that contact lens wear may be intrinsically inflammatory. And then we also have to deal with potential complications like inflammation. And these challenges are a big deal because there's an estimated 140 million contact lens wearers worldwide, but up to 51% of these contact lens users will ultimately drop out, with 20% dropping out within the first year. So why does this happen and how can we prevent it? Now, before I continue, I just want to mention that many of the areas I'm going to discuss have some conflicting data to them or they lack consensus. And some of the points are related to more outdated materials and they're more historical in nature. However, there are some overarching takeaways that are going to be applicable to all of our soft contact lens wearers. So let's dive into the impact of soft contact lenses on the ocular surface and vice versa. But first, just a quick reminder. The ocular surface is more than just the cornea and conjunctiva. It's also the eyelids and the eyelashes, the meibomian glands, the main and accessory lacrimal glands, the goblet cells, and the tear film. So we have to keep all of these elements in mind when we're talking about homeostasis, especially in the context of contact lens wear, because remember, homeostasis is an integrated system. So this process is going to involve all of these structures. So let's start with the lids and lashes. So its two primary homeostatic functions are to provide protection with blinking and to spread tears over the surface as we blink. So what happens when we put a contact lens onto the ocular surface in regards to how it affects the lids? Well, the first thing we see is an increased blink rate. And it's thought that this might be that foreign body reflex blinking, that the body is sensing this, and then we're actually increasing our blink because we feel that foreign body. That being said, increased blinking is not intrinsically detrimental. Unlike partial blinks, which we know do increase dryness, it seems that increased blink rate really doesn't have a negative impact. Now, we also know that there's an increased incidence of ptosis with contact lens wear, and this is just thought to be due to repeat manipulation of the lids with insertion and removal of the lens. Now, what about the other way? How can the surface, or the lids in this case, impact the lens? Well, lid hygiene is a major issue here. So if you have microbial blepharitis, like Demodex blepharitis, which you're going to know you have when you see these collarettes at the base of the lashes, it can have an impact on contact lens wear. Well, it's been shown there is equal amounts of Demodex in both non-contact lens wearers and contact lens wearers. It's actually been shown that contact lens wearers that report discomfort, 93% of them have Demodex blepharitis, so that may be a contributing factor to contact lens discomfort. Additionally, we can get bacterial blepharitis, and one of the signs of that can be that kind of foamy tear film we see here, which is saponification. And what's happening in this case is bacteria are dumping enzymes onto the surface, and these are going to break apart and destabilize the tear film, which can decrease contact lens wear comfort. The tear film is vital to ocular surface homeostasis as it provides protection, nourishment, a smooth optical surface, and helps refract light. And I really want to key on in the context of contact lenses here, the nourishment aspect, because we all know that the cornea is avascular by nature because it has to allow transparency for light to go through. Because of that, it has to get its main oxygen supply from the tear film. So if you disrupt this tear film, you can disrupt oxygen supply. And when you add a contact lens onto the ocular surface, it profoundly alters the tear film. The biggest thing that it does is it's going to split the tear film into two. You're now going to have a pre-lens tear film and a post-lens tear film. And this really destabilizes it. And that's why you're going to get a reduction in lipid layer thickness, tear volume, tear film turnover, and even decreased tear breakup time. Additionally, you're going to get an increase in evaporation and osmolarity. And all this destabilization negatively impacts contact lens wear in terms of comfort, wear time, visual quality. And the lens itself can even dehydrate. And when it dehydrates, it can tighten, which not only is uncomfortable, but can potentially damage the ocular surface. And we all know that the meibomian glands play a major role in ocular surface homeostasis by providing the lipid component to the tear film, which prevents evaporation, gives us that smooth optical surface, and lowers surface tension to reduce friction with blinking. And because of all these functions, contact lens wear in the context of meibomian gland function is a major area of research. However, this is one area where there's a lot of conflicting information and questions that still remain unanswered in regards to the impact of contact lens wear on meibomian gland health and function. But I do want to discuss some of the consistent and widely agreed upon findings. And the first being that contact lens wear alters meibum. So it's been shown that contact lens wear increases the melting point of meibum. So it's going to be more of that waxy consistency instead of olive oil-like. So it's going to be harder for the meibum to be secreted. And this is regardless of whether there's any impact on structural changes to the meibomian glands. Now, where things are a bit more controversial is what is the impact of contact lens wear on the meibomian gland structure itself. Some studies have shown that contact lens wear does indeed cause meibomian gland dropout, where others show no change at all. However, in the studies where dropout was noted, some of the findings that they noted were that gland dropout typically only occurs after 1 year of contact lens wear. And then contact lens related dropout typically ceases after about 2 to 3 years of wear. And the upper lids are more affected than the lower in terms of which meibomian glands experience more dropout. And it's unsure of the exact reason why contact lens wear affects the meibomian glands, but it's thought that it might be due to chronic microtrauma causing inflammation or physical obstruction of the meibomian gland orifices by sloughed off epithelial cells. And of course, again, this goes back to tear film destabilization. If you have a poor lipid layer, you're going to have reduced wear time, comfort, and visual quality. And then the main accessory lacrimal glands, they're producing the aqueous component, and their homeostatic function is to lubricate and hydrate the ocular surface, provide nourishment and also protection by helping to wash away any potential irritants or pathogens. And as we already discussed, you're going to get some destabilization with contact lenses. However, this is where soft contact lenses can also be beneficial. For instance, in Sjogren syndrome, you're going to get a lot of inflammation, and that can disrupt the corneal surface, and you can get a bunch of SPK as we've seen before. Now, one thing though that they found is that soft contact lens wear can help stabilize the surface. In fact, one study found that soft bandage contact lens wear was equal in efficacy to autologous serum tear use. So I've personally seen this clinically. I've had patients with really severe corneal surface disruption, and soft contact lens wear has helped stabilize the surface. And then we look at the conjunctiva, and it's going to contain goblet cells and immune cells. So it's really going to help with protection. And of course, the goblet cells are going to produce the mucin component of tears, which is going to help anchor the tear film onto the corneal surface. And it's also going to lower surface tension. And like I said, it's going to provide that immune protection. So although soft contact lenses only have a relatively small area of physical contact with conjunctiva, there are some signs you want to see that conjunctival homeostasis can be thrown off. And the two big ones to look for will be hyperemia and staining. And the reason why I mentioned these is because a little bit, you could look at redness, conjunctival redness, and think that's only a minor thing. However, what does this signify? And the same thing goes for staining. Staining and injection both show that there's potential stress to the ocular surface. So if you're seeing lots of redness or you're getting lots of staining, especially in the perilimbal area, which is where the lens is normally interacting with that junction between the cornea and the conjunctiva, then you're really going to want to assess the contact lens fit because it shows that it's perhaps experiencing hypoxia or mechanical trauma leading to inflammation. It's also been shown that contact lens wear can reduce goblet cell density and mucin production, which will also contribute to that destabilization of the tear film. And then a particularly interesting area is something called lid parallel conjunctival folds. And what these are basically micro folds that are less than 1/10 of a millimeter in size that are actually caused by friction between the lids and the conjunctiva. And when the lids sit down, they kind of weigh and pull on the conjunctiva, and they make these tiny little folds. And these folds have been associated with contact lens discomfort. Now, they don't know if they cause it, but that's one potential association. And these are different than conjunctival chalasis because when you lift them up, they disappear, unlike conjunctival chalasis where the folds will persist. And one complication we're all familiar with is giant papillary conjunctivitis, or GPC. And this is thought to be due to mechanical friction between the lens, the surface of the lens, and the superior palpebral conjunctiva. And it's thought to be partially due to a dry surface or lens deposits on the lens, or lens deposits on the lens surface. And as you blink over this, this creates irritation, and then these giant papillae will develop. And this is actually very common. In fact, it's thought that almost 1 in 10 hydrogel wearers will eventually develop this at some point. However, it has been shown that this is less likely with daily disposable wear. And the classic treatment for this is just topical steroids and discontinuation of lens wear until it resolves, and recommend refitting the patient into another lens. Lid wiper epitheliopathy is another thing that's commonly associated with contact lens wear. And the lid wiper region is basically a mix of squamous, cuboidal, and goblet cells found posterior to the line of Marks. And its job is basically to spread the tears over the ocular surface with each blink. However, we do find that you get this lid wiper epitheliopathy, which refers to the staining of this region, and it's more common in contact lens wear. However, we do know that it's less severe in SiHys compared to hydrogels. And again, if you see this, what's recommended is that you switch lenses to a lens type that has better wettability and lubricity. Then the cornea has two primary purposes from a homeostatic perspective, and that's providing protection and also providing visual function as a clear refracting surface. But just like all the other components of the ocular surface, contact lens wear can impact corneal homeostasis. And one of the big takeaways that you're going to find is that staining is present in 54% of soft contact lens wearers, but it's a little bit less prevalent with SiHy wear. And again, what does staining mean? So if you see staining with either fluorescein or lissamine, that's going to be a sign of cellular stress because this is going to stain damaged, devitalized, or dead cells. So if you see this, then you know that homeostasis is intrinsically disrupted. And one of the classic patterns we see is this smile pattern, which is this inferior arcuate band of staining. And this is thought to be due to lens desiccation, mainly due to incomplete blinking, because if you blink incompletely, this is where it tends to stop at that inferior aspect. So the lens is more prone to drying out and causing disruption in this area. Now, if you see staining in the limbal region, now you're worried about excess lens movement or poor interaction between the lens edge and the limbus. And then, of course, we've mentioned already, a major function of the tear film is to provide oxygen to the cornea given its avascular nature. However, as we also discussed, lens wear is going to disrupt tear film stability. So hypoxia was actually a major complication commonly seen in the early days of soft contact lens wear. Now, thankfully, there are higher DK modern lenses. This is less of an issue, unless, of course, it can still occur if you have an ill-fitting lens or a patient misuses their lenses. And because oxygen is so intrinsically important to metabolism of the corneal epithelium and endothelium, if you do get hypoxia, you're going to have a lot of potential issues to the ocular surface, including epithelial cell metabolism is going to slow down. You're going to get epithelial cell thinning, endothelial cell loss. And you can actually get increased binding of bacteria to the surface. And two specific conditions that can be related to hypoxia are epithelial microcysts, which are actually thought to be degenerated basal cells. And these are the ones that when you look with retroillumination, they're going to have reversed illumination and appear dark, whereas vacuoles are thought to be fluid that accumulates between epithelial cells, and these are going to have unreversed illumination and appear bright with retroillumination. Now, these aren't as common with modern lenses, but these are two hypoxia-related conditions that you might encounter. Corneal neovascularization is probably the most common non-infectious condition that we still encounter in contact lens wear. And it's primarily driven by hypoxic stress, but it can also be caused by inflammation. And what happens is if you experience hypoxia, they're going to have an increase in angiogenic factors, and you're basically going to get that limbal vasculature is going to sprout off these neovascular vessels in an attempt to rescue and provide oxygen to the stressed cells. And again, we're worried about neovascularization because this can lead to scarring and lipid exudation that can threaten corneal transparency. But thankfully, with most of our high DK lenses, corneal hypoxia is really something we're not majorly concerned about today. That is, unless our patients sleep in their lenses. So that's one of the big reasons why we have to emphasize to patients that they need to be careful about doing so, because it can create a lot of complications. Corneal edema is another condition that we rarely see now, similar to hypoxia. And again, it's really not something we're majorly concerned about unless a patient is going to sleep in their lenses. And what's going to happen is if they do develop this corneal edema, what you're going to see on exam is you might see some striae or stromal folds, and the patient's going to report things like increased glare, halos, or rainbows in their vision. Now, a lesser known impact of contact lens wear on the cornea is stromal thinning. And this is thought that repeated microtrauma causes inflammation between the lens and the corneal surface. And this inflammation causes dysgenesis or apoptosis of the stromal keratocytes, and this leads to stromal thinning. And even less common that we see now with most lenses is corneal warpage in regards to soft contact lenses. This is was more often seen in some older low DK hydrogels. And while uncommon, one serious side effect of contact lens wear is corneal limbal stem cell deficiency. And the cornea epithelium is highly mitotically active. It's turned over every 3 to 10 days, and the source of these cells originate from the limbus. So as I mentioned earlier, if you have mechanical trauma against the limbus or hypoxia, it can damage this delicate structure, and you're going to lose those limbal stem cells, so you're not able to replenish the corneal surface. So you're going to get impaired wound healing. You're going to get reduced epithelial cell turnover, and you can even get corneal conjunctivalization, which can cause neovascularization, scarring, or loss of transparency. So this is why it's so important to make sure you're always looking at that interaction between the limbus and the lens edge to make sure you're not getting potential irritation. And then we have the corneal nerves, which are probably the most underappreciated player of the ocular surface. And the cornea is the most densely innervated structure in the body, and for good reason, because it controls things like sensation, blinking and lacrimation, and protects the eye through reflex blinking. And it also helps with surface maintenance through routine epithelial cell turnover, wound healing, and providing nourishment and metabolism. And contact lens wear has been shown to alter the function of the corneal nerves as well. So we all are aware that most contact lens wearers have reduced sensitivity, and that's thought to be adaptation to the lens being on the surface. However, you might get an increase in sensitivity at the limbus, and this is actually thought because they have specialized pressure sensors there. You're also going to get some reduction near the conjunctiva and the lid margin as well. But one very important thing to note that was found in regards to nerve health is that patients that were experiencing contact lens discomfort actually noted that it was actually noted they had an increase in nerve growth factor. And nerve growth factor is used to repair and maintain the nerves. So this upregulation suggests that when patients are experiencing contact lens discomfort, they might actually be experiencing nerve damage. And this is worrisome because this can lead to conditions like neurotrophic keratitis, when the nerves basically get to the point where they're so damaged, they no longer provide sensation. And this is going to impair blinking and lacrimation. This is going to reduce epithelial cell turnover, and you get disrupted wound healing, and it can cause these ulcers, which can threaten vision. On the flip side of this, we have the impact of neuropathic ocular pain. So whereas neurotrophic keratitis is a reduction in sensitivity, neuropathic pain is an increase in sensitivity. So these are the patients that are going to be hypersensitive to even innocuous stimuli like a gentle breeze. And the interesting thing about contact lenses with neuropathic ocular pain is they have been shown to both help and worsen this pain. And then, of course, there's inflammation, which is a major concern with contact lens wear because, again, it's thought that contact lens wear is intrinsically inflammatory by nature because you're introducing a foreign body onto the ocular surface. However, it is thought that this inflammation is actually subclinical. And the way we typically measure this is through dendritic cells. And these are a marker of an immune response and inflammation. So it's been shown that the conjunctiva actually has increased inflammation with contact lens wear, but it's transient. And even though the lens, you wouldn't really think it would affect the conjunctiva because there's not much physical interaction, it's actually thought that this increase in inflammation is due to transfer of microbes from the contact lens case, then onto the lens surface, and then onto the conjunctiva. So that's why it's transient. Now, there is an increase in dendritic cells in the cornea, and this is thought to be due to chronic microtrauma between, again, the lens and the corneal surface. But this effect is less pronounced with daily disposables. And ocular allergy is another potential concern for our contact lens wearers because we know up to 40% of contact lens wearers will also experience allergies that can cause itching and mucus discharge. And this can create lots of contact lens discomfort that can lead to lens dropout. And it's not just the contact lenses themselves that can disrupt homeostasis. We have the packing solutions in the care systems. So our packing solutions are going to contain things like borate and phosphate, basically to make sure there's no microbial growth. However, these are both potentially cytotoxic to the corneal epithelium. Likewise, multi-purpose solutions normally use preservatives like PHMB and polyquat as antimicrobial agents, but again, these both can cause toxicity. And what can happen is they can leach into the lens and then basically they can dissipate out onto the ocular surface, and it can create significant irritation, including this diffuse SBK like you see in this photo here. And then we have contact lens discomfort. Now, this technically is its own condition. So this is different than contact lens related dryness. So contact lens discomfort is due to the lens itself, not external factors. So the way you would delineate this would be a patient who's completely comfortable when not wearing their lenses, but they experience discomfort once the lens is worn. Now, you can have dryness concomitantly and might exacerbate this, but this is primary lens driven. And they don't know the exact mechanism, but they thought it's due to the nervous component. They have a nervous component and can be influenced by the lens itself. So if a patient is experiencing this, what's recommended is that the patient be refit into a different lens. So now that we've run through all the ways that the contact lenses can impact the ocular surface and vice versa, how do we manage these potential complications? It primarily comes down to two areas: lens selection and ocular surface optimization. So we already established that contact lenses can disrupt homeostasis. However, we also know that soft contact lens wear can be done successfully and safely. So the key to healthy soft contact lens wear is selecting a lens that's going to cause a minimal disruption to ocular surface homeostasis. So to aid in the selection, let's do a quick review of the different properties of contact lenses. The first we already discussed, which is DKT, which is basically how much oxygen can get through the lens. And a higher DK is going to be better for oxygen transmissibility. And then we have modulus. So a higher modulus lens is going to be stiffer, and a lower modulus lens is going to be softer. So the higher modulus lens can be a little bit more irritating because you're going to have that mechanical interaction between the surface and the lens itself. Lubricity is basically just how little friction or how well lubricated the lens is. So better lubricity means you're going to get better blinking, and it's going to be easier for the lid to slide across the surface without friction. Wettability essentially comes down to just how well do the tears spread over the lens surface and adhere to this surface. So better wettability is going to give you better tear spreading. Again, that's also going to help reduce friction. And there are ways we can increase wettability, and this is through surface treatments, through the use of surfactants and plasma treatments, or adding wetting agents like polyvinyl alcohol or hyaluronic acid, both of which reduce surface tension, and that's how they can help with wettability. Now, as far as lens design, these are other things we should be aware of, but we really don't have as much control over these in terms of mass-produced soft contact lenses. But it's good to remember the basic relationships, such as a larger diameter or a flatter base curve will give you a looser fit, whereas a smaller diameter or a steeper base curve will provide a tighter fit. And now on to something that we can control, and that's lens polymer. So we have two primary polymers. We have silicone hydrogels and we have traditional hydrogels. And one of the major benefits of silicone hydrogels, as we know, is it's going to have better oxygen transmissibility. Whereas hydrogels, on the other side, tend to have higher water content, which leads to a softer modulus. Now, that's kind of the historical aspect of things. Now, one thing of note, though, is a higher water content isn't always the best thing, because paradoxically, as water content goes up, you have more potential for evaporation from the lens. And then as the water evaporates, it can actually pull moisture from the tear film, and that can create some dryness-related issues. And this is kind of less of an issue with modern SiHys, because traditionally, even though silicone was intrinsically hydrophobic, they've actually been able to increase the water content, and they've added wetting agents. So modern SiHys have better wettability and a higher water content. So the modulus has actually improved as well. So now most modern SiHys are equally comfortable to hydrogels, and they perform just as well or even better. And as we've discussed throughout the lecture, many times you're going to find that silicone hydrogels have less complications compared to hydrogels. Another factor that we can decide between is lens wear schedule. And here we have daily disposables and we have reusable lenses. And one of the first things to look at is surface deposits. So surface deposits can actually happen in both lens types. However, it's considered negligible in terms of daily disposables because of their frequency of replacement. Whereas if you don't adequately clean the lens, you're more prone to have surface buildup in the reusable lenses, and you can get degradation of the lens material over time. And this leads to variable comfort depending on how long the patient's been wearing the lens. Now, one of the biggest differences between the two is the need for a care solution. So by not having a care solution for daily disposables, that's a major advantage. And one of the reasons is compliance, because most multi-purpose solutions for reusable lenses are two-step. They require rinse and rubbing. However, one study found that 41% of patients never rub their lenses. And that's not even factoring in not topping off lens solution and adequately cleaning their case. So you're getting more and more chances for basically non-compliance and potential contamination. And the other big thing too is that you're going to have preservatives in your multi-purpose solution as compared to not having to even worry about that with daily disposable lenses. And like I mentioned, those preservatives can be irritating to the surface. So eliminating that need for a care solution is a major benefit to daily disposables. Now, however, reusable lenses, one benefit is that they tend to come in wider parameters. Now, this is changing as daily disposables become more common, but sometimes you have to fit patients into a reusable lens just because you need the proper parameters. And again, daily disposable lens cost is decreasing. However, most reusable lenses tend to be a bit more cost effective. Now, you might also hear of some environmental concerns for daily disposable wear from your patients. They're kind of concerned about, I'm using a lens every day and all this and the blister packs, and I feel like that's a lot of waste. Well, thankfully, most of the lens manufacturers now offer recycling programs where you can recycle both the lenses and the blister packs. Now, if you do have a patient in a reusable lens, care solution is a major thing that can also impact comfort. And you have hydrogen peroxide solutions and multi-purpose solutions. And as I just mentioned, multi-purpose solutions, there can be some compliance issues. You can potentially have preservative toxicity as well. With hydrogen peroxide, it's a bit more convenient. It's one step. It's preservative free. And actually, in studies, they found that the hydrogen peroxide solution provides better comfort. And this, again, may be because it lacks preservatives. And it also potentially gives better protection because it was shown to have better coverage against acanthamoeba. So the main takeaways when it comes to lens selection and ocular surface compatibility and homeostatic maintenance are: use daily disposables whenever possible, and ideally a silicone hydrogel material because this tends to provide better comfort and have less potential complications. And if you are using a reusable lens, a hydrogen peroxide solution is probably going to be the better option for your care solution. And now that we've discussed choosing what contact lens to use to help maintain ocular surface homeostasis, I'm briefly going to review how to maximize the ocular surface to lead to contact lens success. So if patients have blepharitis issues with the lids and lashes, for instance, if they have staph blepharitis, I recommend hypochlorous acid because that's what their own immune cells innately use to fight off bacteria. If they have Demodex blepharitis, we now have Xdemvy as the first FDA-approved treatment for this condition. And we also have traditional treatments like tea tree oil and ochre-based cleansers like Ocular. And if they have really heavy lid debris, then manual debridement can be helpful, like in-office procedures like New Lids Pro or Zest or BlephX. And then you can also use the traditional New Lids device for at-home maintenance. And IPL has been shown to also decrease the microbial burden on the lids. Meibomian gland dysfunction is the most common contributor to dry eye, and we already know that contact lens wear disrupts the tear film. So to try to maximize the ability to wear our lenses, we really want to make the meibomian glands as healthy as possible so they can have a really robust lipid layer that can help stabilize the surface even when a patient's wearing the contact lenses. And one of the best ways to do that is with omega-3 fatty acid supplementation, which has been shown to improve contact lens-related dryness. And then we also have more advanced procedures like thermal pulsation, things like LipiFlow, ilex, and tear care that can also help with meibomian gland dysfunction, as can radiofrequency and IPL treatment. And then for our patients who have aqueous deficiency or inflammatory dry eye, the use of immunomodulators like Xiidra, Cequa, or Stasis of Avi, those can all be helpful in bringing down inflammation long-term. And so can steroids for short pulses to manage flares. And then you also have neurostimulatory treatments like Tiravaya and the ITL100 device that can help stimulate tear production to help address this aqueous deficiency. And then, of course, we have our old standby artificial tears. And these patients can also potentially benefit from regenerative treatments like autologous serum, platelet-rich plasma, and amniotic membranes. And again, IPL has been shown to decrease inflammation on the ocular surface. And then for our patients with ocular allergies, we have many different treatments, including the old standby antihistamine mast cell stabilizer combos. There's also a new drop called Allegro, which has an inactive ingredient called ectoin. And ectoin is actually a molecule that is strongly attracted to water. So what it does is actually brings water in tight to it and almost makes a water shield. So it makes it harder for allergens to penetrate and reach the ocular surface. And it's something that you can consider for your patients as well. And then, of course, you have steroids to help with inflammation and immunomodulators like Vercazia, which can be helpful when you have more atopic conditions like AKC and VKC. And we even have contact lenses that elute ketotifen. So we're going to have lenses now that intrinsically are impregnated with a treatment specifically for allergies right in the lens. And then as far as nerve dysfunction, again, we have those regenerative treatments I've mentioned. But we also have oxervate, which is a recombinant form of human nerve growth factor, which is particularly helpful for patients who have neurotrophic keratitis because it can help heal the nerves. And again, we have the neurostimulatory treatments and there's surgical treatments for advanced cases. Now, you may have noticed that I mentioned IPL in several of the previous slides. And the reason for this is that IPL is unique as a treatment because it is able to address several of the underlying contributing factors to dry eye in a single treatment modality. And it has actually been shown to specifically improve symptoms of contact lens-related dryness. So IPL is a great treatment option for our contact lens wearers who are experiencing dry eye-related issues. So as part of our clinic, I see a lot of ocular surface disease patients who are also contact lens wearers. So before I finish up, I just want to share some clinical pearls that I've come across from managing these patients. So a sign of things to come. So contact lens intolerance is often one of the first signs that a patient is developing dry eye. So if you have a long-time contact lens wearer that's coming in with new onset contact lens intolerance, especially if they've been in the same lens for years with no issues, then you should be suspicious that they might be developing dry eye. Another one is do not overestimate adaptation. So we've all heard or have even told a patient, when they put on a new lens that it's going to take some time getting used to it. Now, this might be true from a visual perspective, but as far as comfort, we do know that they'll get a reduction in sensitivity, but it's not going to be a major thing. So if a patient puts on a lens and they are intrinsically a little bit uncomfortable at minute 1, it's not going to get much better hours down the road. In fact, it's probably going to get worse. So, I mean, we've all experienced this. If we refit a patient into a new lens, they're like, oh my God, immediately they're like, oh my gosh, this feels so much better. That's how the lens should feel. So if they're getting discomfort right away, I recommend refitting them into another lens. Another thing, especially with dry eye wearers, is kind of discuss expectations and goals. Many contact lens wearers that experience dryness have been pushed out of contact lens wear for a while, and their goal is to return. And that's something I always want to do, is get patients back into lenses. That being said, this kind of goes into my next point of saving the wear time when they most need it. I tell patients what's most important for you with your contact lens wear. Is it going to the gym? Is it when you go out for social events? And if it does, what I do is I say, if you only can get 4 hours, save it for when you need it. So save it for when you're going to the gym or you're going out to dinner. Don't use it when you're just sitting around the house, because, you know, if we can get you back to 4 hours, we want to maximize those 4 hours. Now, some of the next things I'm going to talk about go a little bit against the grain, but I have good reason for this. And I really do go by the idea of if it ain't broke, don't fix it. And what I mean by this, if a patient comes in and in the current lens, they are truly healthy, they see well, and they're having no comfort issues, then I don't recommend refitting them into a new lens. Even if there's better lenses out there, theoretically, what's going to happen is you're going to refit this patient and they're likely going to be unhappy and want to go back to their old lens. And the reason for this is because for whatever reason, the lens they're currently in is likely biocompatible with their particular ocular surface. And by switching them to a new lens, you might disrupt this balance. So even though we have really great new lenses, if a patient's truly doing good, and I mean truly, so I mean, if you see signs of disruption or stress, you should refit them. But if they're truly doing well, don't change the lens just for the sake of putting them into a newer material lens. And another thing that's a little bit against the grain is using spherical equivalent in certain patients rather than putting them in a toric lens. And the reason for this is toric lenses are amazing lenses that provide really, really good comfort. But most of the time, these lenses by nature have to be a little bit thicker, and you're going to have that rotational element because it has to lock into place to correct astigmatism. And patients who are struggling with contact lens discomfort tend to have a little bit harder time with toric lenses because of these aspects. So what I'll often do is I'll fit them into the spherical equivalent. Now, you might be thinking, well, yeah, but this is going to mean they're not going to get the best possible vision. And you're completely correct about that. But at the same time, it doesn't matter how good vision is if the patient's not able to wear the lens due to comfort issues. So I have this discussion with patients, and many are willing to sacrifice a little bit of visual quality to get a lens that's functional. Now, again, this is within reason. Really, about a diopter and a half is where you can do this easily. Beyond that, you're really going to compromise vision. But for these lower patients with SIL and contact lens related discomfort, consider using the spherical equivalent. As far as artificial tears go, many patients don't know that there are certain artificial tears you can use with contact lens wear. So it's good to kind of let them know that pick an artificial tear that's specifically compatible with contact lenses or is preservative free. And when I say red means stop, what I mean is paying attention to hyperemia. Now, a little bit of redness with lens wear here and there, that's transit's no big deal. But if a patient is consistently getting red eyes that get worse throughout the day with contact lens wear, you should really reevaluate the fit, because again, this hyperemia means it's a sign of ocular surface stress. And this can be a precursor to neovascularization, and it can show hypoxia or inflammation. So redness isn't something that should be ignored. Another really simple one that we often overlook is rinsing lenses when you take them out of the blister pack. Because like I said, the blister pack has antimicrobial agents that can be irritating to the ocular surface. So if you get a patient that says their lenses really sting or burn when they first put them in, tell them just to get some sterile saline to rinse off the preservatives, and that can actually be a major help. Another thing is that part-time wearers are actually good candidates for daily lenses. A lot of times these patients are like, oh, I don't wear lenses all the time, so I don't need a daily. But in reality, that's actually the better option, because they can get a fresh pair when they need it, as opposed to using a reusable lens where they wear it one day and it just sits in their case for 2 to 3 weeks. So I normally encourage dailies. And then just along that line, I really like dailies in general, just from a hygiene and comfort perspective. So whenever possible, I like to start patients when they're new fit in dailies right away. And then my own personal philosophy on complications is you only get one strike and then you're out. And what I mean by that is I'm going to change the lens. So if a patient develops a Claire or lens-related infiltrate in whatever lens material they're wearing, after I get that cleared up, I'm going to refit them because this complication was a sign that that lens isn't super compatible with their particular ocular surface. And then I also talk about lens selection and optimization of the ocular surface. And you really can't do one without the other. However, the one thing that I often tell patients is that no matter how well you are treating their ocular surface disease, if you do not get them in the right lens, they're not going to be comfortable. So you really have to pay attention to both. And then the last thing is just personally try lenses whenever you get the opportunity. Now, your experience, it might be different than others, but it's just a good way to get a more nuanced understanding of all of the lenses. Whenever a new lens comes out, I like to wear it myself. So I know we've covered a ton of information here, but all this can basically be distilled into a few points. And the first is that soft contact lens wear is going to present a particular homeostatic challenge. But we can basically help minimize this disruption to homeostasis by choosing the proper lens and optimizing the ocular surface. And that's going to help us maximize contact lens related comfort and success. And then here are my references. And that wraps things up. So thank you everyone for watching, and I'd be more than happy to answer any questions you might have.
All right, thank you everyone for joining me today. Now we're going to go through a few questions here. So first one we have here is, can you talk a little bit about the fact that soft contact lens wearers seem to have more symptoms of Demodex versus non-wearers? Yeah, so this is a relationship that we see. It's one that I know is an active area of research really seeing the impact here, but it would just make sense from an ocular surface perspective that Demodex blepharitis is going to create a lot of dry eye type of issues. You're going to get more irritation, redness. And as we discussed in the lecture today, when you're wearing contact lenses, you're a bit more susceptible to that ocular surface dysfunction in general. So if you also have Demodex blepharitis on top of that, it's only going to serve to compound all of those symptoms. So if you're finding a patient who's experiencing contact lens discomfort or irritation, definitely look for Demodex blepharitis. And if they have that, you're going to want to make sure you address that. So try to make sure that that's not one of the things that's leading to contact lens discomfort. Then we have another question here, and it's just asking to talk a little bit more about the relationship between wearing contact lenses and Sjogren's syndrome. So this one's a very interesting one because we do know, obviously, if you have Sjogren's syndrome, chances are you're going to be producing less of the aqueous components of the tears. That's going to lead to tear film instability. And as I discussed today, when you're wearing a soft contact lens, that serves to make the tears less stable on its own. So potentially that can lead to further destabilization and have difficulty wearing contact lenses. However, when you have that inflammatory component, which is often present in Sjogren's syndrome, and it can cause ocular surface disruption, you're going to get lots of that SBK. Contact lenses, if you're used somewhat therapeutically as a bandage lens, can actually be more beneficial because it creates this artificial barrier environment where now, even if the tear film is unstable, for some of these patients, they get a benefit from having that extra layer, that protection from the soft contact lens, which can actually help the surface heal. And I've seen that play out clinically myself. So it's something I normally say if a patient hasn't worn contact lenses as a Sjogren's patient, they have significant surface disruption. It's something you can try, see if that helps kind of heal the surface. Whereas if it's a contact lens wearer who also has Sjogren's and they're struggling with that, to wear contact lenses, then you know you're probably going to have to do more of your traditional dry eye treatments to be able to actually help get them to wear contact lenses comfortably. All right, and then another question that we have here is, do you know anything about how much plastic waste materials from contact lenses end up in nature, specifically what percentage? Yes, so we know that it's about 32%, and that's one of the reasons why there's been a very big push over the past few years, especially, to really focus on recycling contact lenses, including the lenses themselves, not just the blister packs and everything like that. And thankfully, as I discussed now, especially because that's become such a big issue, is that we have recycling programs. So I often encourage doctors, reach out to your local reps. They'll be able to help tell you more. I know there's resources online. But definitely encourage your patients, talk to your reps about ways that you can recycle that to really kind of cut back on that plastic waste. All right, here it looks like then we have another question here, and it's what recommended dosage of omega-3s, what specific amount? So what I always do is I recommend when it comes to an omega-3 supplement, you're going to want a high quality reesterified triglyceride based omega-3 supplement with we're going to want at least 2 combined grams of EPA and DHA. So I always shoot for 2,000 milligrams. You're going to want that 2 combined grams because that's going to give you the highest quality that you really need to actually help patients who have dry eye. All right, and it looks like that's all the questions that we had. So again, thank you so much for joining for the lecture today, and thank you for all the great questions. And I hope you guys enjoy the rest of the show.